So it's my real pleasure to introduce the chair of today's meeting, which is Dr. Sai Praveen Harinath from Apollo Hospital Groups, India. Can I hand over to you, Dr. Sai?
Great. Thank you so much, Ilona. Just audio check, making sure I'm audible. Great, perfect. Welcome again to our esteemed panelists from around the world, as well as our participants who have joined in and logged in, and also for people who will be watching this in the future. Half the year is almost over. If you really think about it, 2025, 5 months are up, and what have we achieved in virtual care? Not a lot, honestly. There's so much more that needs to get done. There's so much more that needs to get done. And through the IHF's leadership, as well as Apollo Hospitals and my own hospital leadership, we've decided that it's very important that we begin these conversations and take them to completion and action. With this in mind, we've decided that we would have several leaders in the space share some insights, share some thoughts, share about what they think are ways to overcome the multiple challenges. And today I'm really pleased to have multiple experts here, and I'm going to have them introduce themselves one by one in the interest of time, and just let you know that we will have enough time for questions at the end, and we will be trying our best to highlight the most important areas that today are opportunities, but are also things which we need to overcome in terms of challenges. So I will invite Dr. Huma to please introduce herself, and then we'll go down the line, Dr. Mohammed and Dr. Vishal, and we will have two more panelists from the WHO who will be joining us later in the conversation. Dr. Huma, all yours.
All right, thank you so much. Bismillahirrahmanirrahim. Good afternoon from Pakistan. I'm Dr. Huma Naz. I'm representing the Khan University Hospital in Pakistan. So I'm really, first of all, I would like to thank the International Hospital Federation for, starting these special interest group webinars. And as Dr. Praveen rightly pointed out, that this is a platform, and I'm really excited and confident that through this platform, we'll be able to not only share ideas, but have a candid conversation, as well as build partnership and bring some healthcare solution for virtual care. Thank you.
Perfect. Thank you, Dr. Huma. Well said. Dr. Vishal.
Thank you, Dr. Sai, and very good afternoon or morning to whichever part of the world you're from. And I'm Dr. Vishal Patel. As said, I'm the Chief Medical Officer here at MP Shah Hospital in Nairobi, Kenya. And I think also excited to learn from each and every one of us here, from the panelists as well as other members joining in. Thank you. Looking forward to a good session.
Thank you. And Dr. Mohammed Al-Mali.
Thank you, Dr. Sai. Thank you for the International Hospital Federation. It's an honor and a pleasure to be here among esteemed leaders. As my colleague have mentioned, collaboration is a key. I'm Dr. Mohammed Al-Hmali. I'm the Cooperative Business Development Director at Dr. Suleiman Al-Habib Medical Group in the Kingdom of Saudi Arabia.
Thank you very much. So I'm going to jump right in and ask Dr. Vishal first. What's Kenya seeing right now in virtual care? What do you see as the current trends in Kenya? And just as a reminder, as Ilona mentioned, we'll keep our answers brief. We will have plenty of opportunity to have further conversations and discussions during this course of today's conversation panel. So Dr. Vishal, what do you think is the current status of what's happening in Kenya?
Thank you, Dr. Sai. And I think when we talk about Kenya, to begin with, Kenya has a growing medical industry. It tends to be the hub of East and Central Africa, especially Nairobi, when it comes to healthcare provision, healthcare infrastructure. Hence, it was one of the early adopters of virtual care in somewhat limited capabilities. And then COVID, of course, accelerated use of it a bit more. And a lot of it started with mainly looking at resource constraints, and mainly human resource constraints, and identifying how we're able to have telemedicine work for consults with specialties, especially subspecialists, to provide care to areas where those specialists may not be available. But then as COVID came, and with the restrictions, thankfully, Kenya was one of the countries which had early lockdowns and curfews, etc. And with reduced movement, telemedicine gained traction very quickly, very fast. And since then, we've seen quite a bit of growth in mainly looking at people, facilities, looking at investing a lot more in ICT infrastructure to enable virtual care. And the other thing is that the regulatory authorities also have come in strongly and look at how to make sure that this is done in the correct manner, with Kenya adopting a Digital Health Act and also coming up with a framework to have a digital superhighway, which basically will also include the healthcare sector and how to bring all the sectors together. But as part of this as well is where it has helped, and I'll show you a bit as we go along, is that for some facilities where we may not have enough resources to provide timely diagnostics, that's where it has also come in, where you would have virtual care involving either diagnostics in terms of ECGs, teleradiology. Some facilities have also set up tele-ICUs to help with improving care. Yes,
so Dr. Patel, so just one question I always wondered about, and by the way, if you have a slide, Ilona, if Dr. Patel has a slide, he can put that up. What is the rural-urban mix in so in terms of what happens there? Is there a understanding you have? Like, is there like a lot of referral you get from the rural areas of the country? How does that work? And I know yours is a pretty large tertiary care hospital with even Joint Commission accreditation. So from that standpoint, I'm assuming you get a lot of inflow from other places. How does that work with your virtual care strategy?
Yes, so we do get referrals from the rural areas. Apart from Nairobi, there are about 4 major other cities which would have tertiary care or at least specialty care hospitals. And from there, what tends to happen is that the referrals we would get is from those facilities where now patients would be sent to a center where they are able to get subspecialty care. And when you look at the population in the urban to the rural areas, of course, the rural areas in Kenya are form about 65% of the population. Hence, you do have quite a large population there. And even though they're in the rural areas, you see that non-communicable diseases are increasing in those areas as well, affluent diseases of affluence, and hence you find more and more now require multidisciplinary care where we do see opportunities for virtual care coming up in that. And the one issue, however, that still remains is infrastructure to try and enable people access.
So I'm going to have you hold that thought. That's something very important, which you're going to touch base on later in the course, because I'm thinking that's going to be a common thread to all of us. I'm guessing that, but we'll hold that thought and then move on to another part of the world now. Thanks, Dr. Vishal. So we will touch base on the points that you've raised, especially the rural-urban, the infrastructure issues, and I think we'll also like to learn a little bit more about the ECG that they've done. We'll talk about the tele-ECG model also during the course of today's conversation. I'm going to move to Dr. Huma. At Aga Khan, I understand you have a fairly global network. And how does that play into the virtual care scenario? In fact, I also think you have something in Africa too. Would you want to just comment a little bit about how Aga Khan approaches this entire ecosystem of virtual care?
So basically, Dr. Sai, thank you so much for this question. So when we look at specifically the LMIC scenario, the area in the geography where we operate, so we see, and as Dr. Patel also mentioned, so the virtual care, the tele models were available for over a decade now in these areas, in our areas as well. But the COVID came and we saw a magnanimous surge. But now, after COVID, the rates, the consultation or the business has gone down. But I believe that it has reached a very strong baseline, and it is something which we can build in future. So areas like Pakistan or Kenya, in which our health network works, we see there are issues which relate to divide between the rural and urban gap. So we see that almost 80% of the hospitals in the urban areas are they are providing virtual care. But when we go to the rural areas, we see that the coverage is not good. And then the points which have been highlighted by Dr. Patel as well, and by yourself also, that the infrastructure and the financing model are the big barriers which we see. So, but in our network, we are trying to develop different models through which we, kind of not only integrate, but, integrate the care, but also provide a good patient-centric experience, because there are far-flung areas, remote areas, there are things which we want to do, and a virtual mode is a good way of going about it. The good thing, as I've mentioned in my slide, you can see that, there is a very good a broadband usage in our country, and a lot of people have, access to mobile. So we started with computers and laptop, but with the growing increase in the mobile usage is something which will going to help in very near future to broaden our horizon for virtual care, especially in.
So that's super interesting. Can you comment on the tele-triage bit that you've listed in your services at Aga Khan? Do you have some thoughts on that?
Yeah, so that is something which I would say we tried, because there's always a need that people, before coming to ER, they want to see whether they should come to a clinic or they should come to an ER or an urgent care setup. So that is something which we experimented, and I would say it was an experiment, because we could not keep up with the requirement, the resource required in order to keep that tele-triage. But that is something, it was almost a virtual visit where you can triage and say whether the patient needs to come to the urgent care or should go and get some medication or something like that. So
Perfect.
we have
Thank
done some B2B in which, we provided assisted teleclinic. So rather than connecting patient from their home, we ask them to come to a medical center, because one of the barrier is the lack of examination or assessment. So,
Correct.
medical small center, if present near the home, patient can come there, and then from there, the connectivity issue was also, addressed.
Got it. Perfect. Thank you so much, Dr. Homa. And I think it'll be lovely to now understand what Dr. Mohammed can share about what happens in Saudi Arabia. And he's been involved in many institutions, and I think he's going to share about what he's doing currently. Dr. Mohammed, your turn, please.
Thank you so much, Dr. Sai. Well, Saudi Arabia stands today as a digital and a health leader in the region, ranked just recently first in digital infrastructure in the Middle East and fourth globally. So also another remarkable achievement, just recently, we have performed the first worldwide fully robotic heart transplant surgery. So this shows you the commitment for innovation and the pace that the kingdom is moving toward. And today at Dr. Sliman Al Habib Medical Group has emerged as a benchmark for private sector excellence. We are the largest private healthcare provider in the Middle East, over than 25 hospitals across the Kingdom of Saudi Arabia and GCC. We're a public listed company with a market cap over 100 billion. We're among the first region to implement a full integrated healthcare information system. I remember 2 decades ago where we wanted to have a digital transformation, a seamless, paperless, and ensuring having a unified medical record to ensure the outcome for the patients. We've received a Guinness World Record for our tele-ICU, the largest around the world, as well for our command center. And just to share some numbers, our Life Care, which is a 24/7 life care platform, and we have our virtual clinics into it, just in 2024, over than 683 million transactions. That shows how digital transformation is happening, how our population after COVID, as my colleagues have mentioned, are becoming and relying on technology and seeing the value that it brings with it.
That's great. Thank you so much, Dr. Mohammed. That's excellent. And I think I visited Seha, I think I mentioned to you once before, a couple 2-3 weeks back, and it's amazing just to see the technology and infrastructure. So I'm going to jump right into, I know everyone wonders, okay, who's going to finance all of this? that's a whole separate conversation, which we will have in July. It's an important conversation. We will try to pull in the right people who can answer those questions also, because ultimately that does determine a lot of what we do in virtual care. But I'm going to ask Dr. Vishal, and we touched on the infrastructure piece. I promised we would talk about it. Now, there is the physical infrastructure requirement of, computers, buildings. There's also the virtual infrastructure requirement of the broadband network, etc. Where do you see the challenges now, and where do you see this dissolving, especially from a Kenya perspective? What do you see as a barrier to adoption from an infrastructure perspective, Dr. Vishal?
Yes. So one thing with, again, Kenya, when I'll compare it to the region, East and Central Africa, connectivity and internet access is improving, and it's much better than other places. Bandwidths are much better because of the undersea cable that connects the country via the Middle East to the rest of the world. However, what tends to happen is that you find we were among the first ones as a country to adopt mobile financial transactions. Many of may have heard of M-Pesa, and what that has done is it has made sure that that there's at least financial transactions, digital financial transactions available all across Kenya, including the rural areas. However, that relies on the GSM signal most of the times for the rural population. And what that tends to happen to do is that they're not using internet as much per se. They're using that GSM signal for other things, but not internet as much. So we do have that one challenge of the masses having access to low latency internet that can at least enable virtual care consultations and transmission of data. However, with ever increasing urban infrastructure, from urban to urban areas, it's becoming much easier. The other bit of looking at having the right human resources as well in terms of their infrastructure for someone to now look at implementing of some of this infrastructure. Again, Kenya leads in terms of ICT sector within the region, but it is something which has come out as a deficiency within the ICT sector to try and implement this as en masse.
That's great.
Then,
so I think that's
yeah.
super interesting, Dr. Vishal. So I was also going to, I'll get back on the point you talked about the internet, because I know that satellite internet is making a big difference. How many of you have tried it? Has anyone here tried satellite internet? I mean, I know I tried it on a plane about 6 months back. I was the only one attending a meeting with video on. Everybody else did. My speed was 285 Mbps on a plane, which is really fast. And if you can think of the healthcare implications of a solution like that, I mean, you're immediately bringing in access. And I think those are the kinds of things which might really help. I want to jump, Dr. Vishal, thank you so much for chatting about the infrastructure challenges. I'm going to ask Dr. Homa about, we've talked about this before, the human resource aspect, the physical infrastructure, and the virtual stuff. But do you see there's a cultural issue with acceptance of virtual care? Have you noticed that in the work that you do in primary care, especially? Is that a challenge that you've seen? And I will invite comments from Dr. Mohammed and Vishal too about the same point.
Yeah, Dr. Praveen, I think I would say that is something which is not being highlighted the way it should have been. But I think in the growing population there is a big cultural barrier. For example, nowadays we see that people who are, especially the elderly, they think that the care part cannot happen without a physical touch. So they want to come and visit a healthcare facility rather than receive a virtual care, and we see a lot of resistance into that that attitude. Also, people have a belief that the care is not complete unless and until it is the doctor examines you, or they listen to your heart and check your pulse. So their belief on the completeness of the care is something which we as a healthcare professionals, we have to kind of address through community engagement. And related to these cultural beliefs and aspects, I think there is another factor which I think it's very relevant to our area is the digital literacy. And I think Dr. Patel mentioned some aspects of it, because the platforms we use, the technology we use is mostly English, and which is not our language, which is known to everyone. And the applications and the platforms we use, they are very tech savvy. So in order to have more acceptance into the population on every segment of the people we serve, I think we have to
No, I
grow
think
into.
Oh, absolutely. So I think you're right. And before Mohammed and Vishal chime in on this aspect, I think there are some things where we unnecessarily complicate things. I mean, I've known companies which have actually looked at giving not smartphones, but dumb phones, essentially with a button to press to connect and a button to kind of do some very basic functions. And perhaps we need simpler solutions, especially for people who are elderly, not used to technology, or if there's a barrier because of perceived technology being an issue. I think that's something we should look at. The other thing that I've also explored and had conversations with others is on the way to get vital signs. You did mention that a lot of times people want to be examined, but nowadays, we do have mechanisms for getting virtual vital signs. I can measure heart rates to the camera, pulse oximetry to the camera, and even maybe blood pressure. So there are companies doing that. So it may be interesting how in the future, not the distant future, I'm talking about, I don't know, in a month, we'll be getting new things coming in, which will actually help us even measure vital signs. And as Dr. Muhammad talked about robotic surgery, you can get robotic examination, haptic examination. I mean, these are all not science fiction anymore. They're available. But if you can get the July conversation will be interesting. Who's paying for all this? So I think is going to be one of the interesting things we'll be talking about. Dr. Muhammad, your thoughts on the cultural aspects for about 30 seconds or so, and then Vishal, your comments on the same cultural aspects which you have seen, both from the patient and the provider aspect.
Sure. Thank you so much, Dr. Sai. As my colleague, Dr. Huma, mentioned, age segmentation plays a big role, which segment is adopting the technology. And if I would love to add is the specialties as well. For example, we see a lot of adoption in mental health and follow-ups in women's health. So all of that are specialties that are really utilizing and leveraging virtual care on a day-to-day, and it's become a business as usual. I think if I want to say my last thought on this is that virtual care should be a hybrid model with physical care. So it should complement and not replace. And I think that's what those specialties and other specific specialties are using to ensure the continuum of care to the patients.
Absolutely. I think that's perfect. And then the one quote that comes to mind is virtual care is care too. I think it's a logo for one of the organizations where virtual care is really, ultimately it is care. And Vishal, your thoughts, please.
Sorry, I was muted. Yes, so I think for us, it's similar to what Dr. Huma has brought up. Many patients, especially when you look at what also Dr. Mohammed said, age segmentation, the elderly tend to want to have that one-on-one interaction. The younger patients are more acceptable of virtual care, but then their fears may be a bit different. The younger patients may worry about, is their data safe? Are they getting value from the consultation they're doing, for example? So their concerns are a bit different. On the other side, the other bit of also looking at healthcare providers, again, depends. I think we've seen a difference with some in that way the younger doctors are accepting that much quicker than some of the more seasoned doctors who would want to do those examinations, who would want to make sure they're examining a patient.
Great. So I think, great points by everybody. So one of the things that comes to mind is, as we have so far touched upon, I think everybody on this call knows that virtual care is important. It is a solution for many of the challenges we face. There are issues with the infrastructure. There are issues with broadband. There is also the cultural acceptance issue. But overall, the general direction seems to be that people are more accepting of virtual care as one more way to do things. And as an outpatient doctor, for many of us, for inpatient doctors also, virtual care is fitting into the day-to-day workflow. You might see a physical patient, then you might do a virtual appointment, things of that sort. And I've seen that happen in my practice, at least. Now, in terms of the other aspect of what I think we should really be touching on, I know the WHO team will be joining soon, and we'll hear a little bit more about the global perspectives. But I'm just curious to hear very briefly about, are there situations where people actually prefer virtual care beyond mental health? Have you seen anything of that sort? Is that something that you've noticed in your practice, Dr. Mohammed? Any comments on that?
Yes, we see a huge adoption for virtual care, either from a doctor to doctor or doctor to patient. As I mentioned at the beginning, tele-ICU, it helped us where we have a 24/7 tele-ICU. So it's really if once the value and the process is being put together in a very good manner, then you will see the result and the value. Just to mention what kind of value or impact we are seeing, as we know that, for example, trying to elevate the pressure on physical hospitals, trying to limit as well or bridge the gap on workforce as we are witnessing workforce shortage. All of that virtual care have brought tremendous value in these areas. So that's why it became part of our practice on a day-to-day, and it became an integral part actually. When we talk about model of care, when we talked about value-based care and population health, these are really important even to follow up on programs that are tailored on a population health to ensure accountable care organization. So that's really important.
Absolutely, absolutely. See, so I do remote critical care. I've been doing this for more than, 14 years now, that I do remote intensive care for the United States from India. And I've seen that, at 2 a.m, when you're the only provider who's talking to a family and a patient, and they can see you face to face, and you're helping someone who's really sick on the other end and triaging what can happen. I mean, families like that because it's not the same as having the doctor at the bedside, but at least you're able to get over what I call the knowledge asymmetry. The asymmetry where the doctor knows more than the patient or the specialist knows more than the primary care doctor. You can overcome that and create a level playing field using virtual information. The other big thing, which I think is not really a challenge, but something we should reflect on, is aviation does this seamlessly. You can fly anywhere and the air traffic controllers are thankfully talking to each other. Finance does this seamlessly. You can use your ATM card anywhere. Assuming you have money in the bank, you're going to get it out in whichever country you're at. So I think from that standpoint, I believe we should be really looking at the high standards that these fields maintain, and healthcare probably needs even higher standards. Ilona, I believe our colleagues from the WHO have not yet joined, correct? Dr. Karthik and Arash?
That's correct. We're expecting them in the next 5 minutes or so, but
okay, perfect.
Yeah, I think we can carry on.
Oh, perfect. So great. So I think one of the thoughts that I've had in the past in terms of the virtual care aspect is, what are the cross-border challenges? How can we simplify it? During COVID, it was really easy, right? You were able to do and support each other. In disaster settings, we have countries helping each other. Why can't this be the normal? Any comments, Vishal? Just your philosophical rumination on why this may or may not be happening as long as standards are met?
I think we need to start with the standards first. The reason I bring this up is that, for example, some countries like even Kenya right now, we have not yet fully had virtual care looked at in terms of regulation and how it's being regulated. There is an eHealth Act that is still not yet finalized. And the reason I bring this up is that, for example, if today Dr. Sai is providing tele-ICU services to a patient in Kenya, for the Kenyan doctors to implement the recommendations Dr. Sai is providing, they would have to do it based on as if it is their recommendation. And that's where now this regulation becomes key, where I think there should be credentialing and regulation of the expert on the other side by the native country's board. Because then what tends to happen, and we've seen this a lot, where then now specialists in Kenya, for example, become a bit hesitant to say, it's my license which is at risk if something goes wrong. So I think that bit needs to be improved upon for us to have this cross-border working.
Absolutely. So I think you're absolutely right. I think the same protections that a physical provider and a patient interaction would have, it should apply to the virtual field too. And what I've seen two approaches to this is, one is to use it as a second opinion consultation, and the decision making is by the bedside team. But I've also seen where the responsibility is shared, where you're not off the hook just because you're far away, because now you have access to all the information. So you should be able to assist the provider on the other side. But I believe these are thorny issues which we should address, because they are probably the reason people are hesitant to do and take up virtual care in a larger scale. Patients really want it. I mean, it's such a convenience, right? Not having to drive through traffic. And Ilona, a quick question from the IHF perspective. There was a question earlier. Since we have a minute, I'm going to kind of deviate very quickly. Now, the IHF is having great conversations. Thank you, Dr. Akbar, for commenting on that. How else are we helping members address the challenges faced in virtual care expansion? Ilona, do you think the idea just popped up? Now, the Geneva Sustainability Center is measuring our carbon footprint. Is there a way for us to measure what happens in virtual care and what are the savings we're bringing in? I know that I have done through Apollo Hospitals a study where we looked at what is the savings for a patient who's going to be coming from far away, what is the economic saving as well as the fossil fuel saving. Is that something that'll be interesting, you think, to our general IHF audience, Ilona?
Yeah, absolutely. I think the interest in virtual care is huge within the IHF membership. And further to Abdul's question, I think what we're doing at the IHF as a membership organization very much depends on what our members would like us to do. So one of the things that we provide is platforms like the Virtual Care SIG to share best practices and ideas and connect people around the world to potentially collaborate and work together. But Dr. Sai and I, we've also talked about perhaps putting together some kind of white paper, looking at different aspects of virtual care, which we would love to get representatives from the IHF membership on board with that. We at the IHF Secretariat don't provide that level of technical input, but you as the experts, we would be very happy to coordinate and get that level of technical input from you to put something together, whether that's a checklist for IHF members interested in working more in virtual care, or whether it's a white paper looking at best case, good case studies of what people are doing around the world. Would definitely be open to lots of ideas.
Perfect. Thank you so much. Thank you for that. I think we are perfectly timed to invite Dr. Karthik from the WHO. Thank you, Dr. Karthik, for joining, and really appreciate you joining in spite of a busy schedule as well as other calls. I believe Dr. Areshan also will be joining in shortly. So Karthik, we have had a very fun, interesting, wide-ranging conversation on what really virtual care has been doing for the countries. Vishal is from Kenya, Dr. Muhammad is from Saudi Arabia, Dr. Huma is from Aga Khan in Pakistan, and we've been conversing about what are the things we have achieved as successes. We've also touched on what the challenges could be, both from an infrastructure as well as perhaps a cultural standpoint, where sometimes people prefer having in-person communication and in-person examination. We also touched base on the recent and rapid advances in technology allowing remote vital signs, remote medical care to be provided. And we were going to kind of segue right now into getting your opinions as a little overview from the WHO in terms of what is it that you see from a CRO perspective? You're in the Southeast Asia region. What are the major opportunities that you have seen in virtual care? And when Dr. Arash joins in, his opinion on the EMRO region. And what do hospital leaders, now we have an audience of about 30 people right now, who are from around the world, and what do they as leaders, as consumers of virtual care need to build successful hybrid care models? What do you see as an opportunity? And are there any insights you can provide for us? A couple of minutes on that, and then we can kind of go a little deeper into some of these things. Thank you again, Dr. Karthik, and kindly introduce yourself very briefly too, so the audience knows who you are. Thank you.
Wonderful. Thank you. Thank you, Dr. Sai. It's an absolute pleasure, and I'm really privileged to be here. My name is Karthik Arappa. I'm an internal medicine physician, but trained, I did my PhD in radiation oncology. I'm a faculty at the Yale School of Medicine and at UNC Chapel Hill. I'm also the regional advisor for digital health and AI in the Southeast Asia regional office of the World Health Organization. But also, just complete disclosure, I'm also a permanent civil servant for the Government of India. I was Secretary Health and Secretary IT in Government of Punjab. I'm essentially on a deputation from Government of India. So just 3 different affiliations, primarily with WHO, but an affiliation with the government and also an academic affiliation. Now, broadly, there's a wonderful question that you asked, Dr. Sai. And WHO, especially the Southeast Asian region, is an extremely exciting region. We have about 10 countries in the region: India, Bangladesh, Thailand, Sri Lanka, Nepal, Maldives, Democratic Republic of Korea, Timor-Leste. So there's a wide range of countries. So we have mountainous countries like Nepal, Bhutan. We also have island countries like Maldives, Sri Lanka, and Timor. And then we have large countries like India and Thailand and Bangladesh.
Great. And in terms of what you see as opportunities for virtual care, and I kind of want to go a little deeper beyond the COVID experience. During COVID, it was a natural fit. Where do you see virtual care playing a role, both in the population health aspect, as well as perhaps into a little more in-depth, advanced level tertiary care?
So the first thing, let me start with foundations, right? Before you go for care, the most important things that you need in digital health or even virtual care, the focus is not on technology or digital, right? The focus is on health. And now to accomplish that, you need some foundations. Now the foundations for virtual care is essentially going to be the digital health strategies, right? What you want is at the national level, you want all your countries to have those foundational documents which lay down the basic struggle. Like, for example, if you don't have a physical digital infrastructure like roads and rail networks, you need access to network, you need access to data centers, you need access to. So these are basic foundations that you need. And that is something which comes through these foundational documents called the National Digital Health Strategies, which are essentially costed action plans that countries develop. So there are 129 countries in the world which have these digital health strategies. But uniquely, Southeast Asian region is one region where 80% of all the member states have a costed action plan. So that means there is a foundational document, there's a foundational work that on which countries are building. Now, for example, to give you the context in India, India has something called the Ayushman Bharat Digital Mission, which is essentially the foundational document for anything digital in the health of India. So if you want to talk about the telemedicine, essentially you would need all these basic foundational building blocks. And so countries in CRO have essentially focused on that. The second thing is, of course, regulations, right? Now, in terms of a telemedicine law or a virtual care law or a non-binding guidelines, again, out of the 10 countries, 7 countries have a telemedicine law or a non-binding telemedicine guideline. The third key thing also is that amongst all the countries in the world, CRO is one country that contributes the highest to open source, standards-based telemedicine or a digital health open source tools. So CRO countries have actively been promoting and adopting open source standards-based digital public goods, not only in virtual care, but also in general. So for example, in telehealth is a telemedicine nonprofit that has been promoting these open source digital public goods in the entire region. So as a region, both in terms of creating the legislative framework, the regulatory framework, as well as promoting open source standards-based digital tools, Southeast Asia has been extremely in the forefront. So I just wanted to flag that, and I know there are other colleagues to speak,
no, that's
so
great.
just wanted to lay down that.
No, perfect. So I think that's critical, and I think which is why we need folks like you who are experienced in the structural organization of this entire space, which is very important to give, I think, confidence to users that this is being done with the highest level of the detailing is done in a very I would say in a positive way, where we're not really creating barriers, but we're really creating a pathway to make it easier for the next generation of people who need to do this. And I'm going to invite Dr. Rashidian. Sir, can you kindly tell us what you do in your region? And similar to what Dr. Karthik mentioned, can you tell us what you see as the opportunity and perhaps any major challenges that are being overcome?
Hi, Dr. Sai. Hi, colleagues. It's a pleasure to be with you, and apologies for my delay in joining. I had informed Ilona and all colleagues. We were in an important meeting for the WHO and couldn't leave earlier. I'm Arash Rashidian. I'm Director of Science Information Dissemination in WHO Regional Office that has responsibility in areas of health information systems, digital health, evidence-informed policymaking, and also research capacity and governance. Okay, so going to the question that you're asking, and I've missed the previous discussion. I apologize if I repeat something that other colleagues have already highlighted. When we talk of virtual care and systems for provision of remote care to people, so obviously there are several elements into it. I mean, following what Karthik said about the infrastructure, about the governance mechanism, about the holistic view, about the sort of linkage with things beyond the healthcare. I mean, those are absolutely important. Those are essential. And there are many more details to that everybody's probably addressed already. But when it comes to the care itself, I mean, transferring that into action is also another ball game that everybody's aware. I mean, one area that I know is the concern of the panel, for example, is about financing virtual care. So when we talk of financing, I mean, telehealth, telecare, I mean, anything about sort of the remote care, virtual hospitals, etc. Part of it is that about infrastructure, about access, about provision of care, about expertise, about competencies. I mean, there are a lot of things on how to do it better, how to make sure it's possible, how people receive it. But when the issue of financing comes in, there are other elements related to that that makes it much more complex, and they are not related to the virtual care provision. It's actually related to the governance of the health system as a whole. So imagine, I mean, let's say you have a virtual hospital, or a virtual clinic. I mean, many private clinics, they did that on their own during COVID pandemic. Now, a lot of those have become formalized. So you provide virtual advice, remote advice to other people. Let's say even if you are being paid and you have financing, there might be consequences, positive or negative, for the advice that you are giving. And there might be other people that need to take care of those consequences. What would be and there are other people who are involved in the sort of real care, I mean, face-to-face care for the people, and how to link those together. And these are not just issues of sort of, I mean, how to look at it from inside the virtual care modality, about the sort of digital health, is about how you look at it from a health system perspective. And a lot of arrangements for that, I mean, in many countries that do provide, when you are linking between organizational divides, let's say private sector and public sector, you are linking about different jurisdictions. So you are in the capital and then you are giving services to someone remotely elsewhere. There is plenty of challenges that are still need to be addressed. And of course, a lot of that is with the financing, because the financing part is also about the incentive. I mean, if I do this, what's the benefit for me? I mean, we need to look at it from the provider point of view, but about the system point of view. But at the same time, how can I handle the costs related to that and the accountability that might come with it? So
thank you. That was perfect. No, you're perfect, Arash. And in fact, we have dedicated an entire future episode conversation on the finance piece, which ultimately is going to be what may determine a lot of these factors, even if there are good intentions on all sides. So perfect. Thank you so much, Arash, for touching base on that. And just to segue a little bit backwards into Dr. Mohammed, where do you see the private-public sector partnership happening in the virtual care space, based on your own experience in Saudi Arabia? Because of limited time, can you just keep your answer to a short minute or so?
Sure, Dr. Sai, thank you so much for this question. But if you allow me first, just to touch upon some of the questions or previous questions. We know that healthcare, since we talked about regulation, is over-regulated system. Maybe here in Saudi, what we have witnessed and seen, how the collaboration among government entities, where some initiatives like the regulatory sandbox, where also a partnership with the Saudi Data and AI Authority, and some initiatives like the Unified Medical Record of Nafis, that really helped the transformation. And this has really helped the private sector, where it can collaborate and share the information and the struggles, where the government becomes more agile in changing and coping with the rapid innovation and the pace that we are witnessing in healthcare. And we know that the rule number one in healthcare is to save the patient. So patient safety is at the forefront, especially at Dr. Sulaiman Al Habib Medical Group, where a lot of, for example, virtual hospital project where we collaborate and ensure that we bring our part of strength and expertise and knowledge, where we share it with the government entities to ensure at the end where the patient benefit from this. So a lot of different initiatives are happening nationwide, and you touched upon how can virtual care play an impact sustainable development goals. And we just recently last year published and how virtual care has an impact on that. So I just wanted to share my thoughts on the previous two questions. Thank you so much, Dr. Sai.
Perfect. Thank you so much. And Dr. Vishal, jumping to some topics we kind of touched on a bit earlier on, do you see the hybrid model as a successful way to do this? Perhaps partnering with another institution for virtual care, or perhaps partnering a virtual care company, partnering with a physical infrastructure. Do you see any hybrid innovative models which might bring about a little more equity and access into the space?
Yes, definitely. I think with the hybrid model, at least what happens is that there is existing investment into certain infrastructure. There is existing investment into, let's say, for example, human resource, and then where we can do what that helps with is also is leveraging on strengths that where some of these existing companies have already proven their worth, I'd say, in virtual healthcare in the sectors that they work in or the regions that they are operating in. So that definitely would make it more accessible here. It's already happening in a few spaces. As I had said, for example, we at MP Shah have collaborated with a provider for ECG reporting. And what I was showing earlier in one of my slides is about from the primary healthcare model, we've had over 5,000 ECGs transmitted and reported with an average turnaround time of about 3.5 to 4 minutes. And from that, we've been able to at least get almost 40 critical ECGs, which could be given treatment immediately, apart from just those, let's say, for example, that were abnormal. And we could only achieve that because there was an existing model available.
Absolutely. So I think what's amazing to me is I'm at Apollo Hospitals in India. We see a lot of private patients, but we also have a lot of partnerships with national government entities. And I see that the virtual care is a tool. It really is a tool where you can extend the care that needs to be done. We do tele-ECG, we do tele-intensive care for multiple locations around India, for example, and now even to Indonesia. What I've noticed the similarity is that ultimately you do need champions. And I think there's a comment put in by Sean Greenlee that you need a champion. You don't need just a champion from the physician perspective. I think you also need a leadership administrative champion. I'm fortunate in my institution that virtual care is mainstream. It is not a side project somebody's doing, which is kind of why we are supporting the IHF in this entire initiative, because we truly believe that virtual care can be a tool to enhance access to care. One area which I have not seen many people comment on, though, in webinars, etc., is that virtual care is very important, I believe, even in inpatient acute care in low-income countries. Take the very simple example of dengue related illnesses. When dengue patients get critically ill, there's a very specific way in which you need to manage the critical care aspects. Initially, you give a lot of fluids, then you give less fluids. So those kinds of simple things can even save lives. When we did an analysis of who are our patients we are seeing maximally for ventilator care, most of them were people with pesticide poisoning. So I think there are some very cultural things which happen in some regions which actually can benefit from virtual support. In fact, virtual management of ventilators, virtual cardiology, virtual neurology has a huge role that is being shown in many developed economies for early stroke management. So I think there are some use cases which fit virtual care very well. There are others which don't. And another comment mentioned in the chat by Ms. Greenlee is about long-term conditions. Absolutely. Diabetes, hypertension management. And I was a few months ago in a conversation where I was able to listen to the Indonesian health minister who actually talked about his idea of a virtual care. However, what he did was he was starting to train ground level mothers in managing diabetes and hypertension and immediately escalated his access to people who can make a difference. So I think there are many ways of combining solutions, and maybe there's a little bit of requirement on our part as clinicians to have an open mind as to being able to build solutions which may not be directly in our own space, but will ultimately have the same outcome of improving patient care. So we've had an amazing discussion so far across the spectrum. And Dr. Rashidian, you actually gave a wonderful summary of what we had already talked about. And it was a very nice, concise overview of opportunities, challenges, infrastructure-related issues. And also, I think, Karthik, you gave us an amazing overview of the government related aspects to it and the size and scale that only government can achieve. And I think it's truly a partnership because patients are going to be moving back and forth across wherever they get the care that they need. And we've had great points from Saudi Arabia, Pakistan, and Kenya. I'm going to put you all on the spot a little bit here, and hopefully we'll have a little bit of time for questions. Initially, I was going to say, think of a sentence to summarize the entire aspect of the biggest opportunity that your organization has in the provision of virtual care in the next 5 years. But I'm going to change that question around a little bit. I'm going to ask you for a word. Give me a word which encapsulates what you think is the way that your organization is going to focus on virtual care for the next upcoming years. I'll start with you, Vishal.
I think for me, it will be PPP, public-private partnerships.
Perfect. That completely makes sense. Dr. Huma?
Low cost, high impact.
Perfect. Still a phrase, but I think it makes sense. Great. Dr. Mohammed?
Well, value-based care for sure.
Perfect. And Dr. Rashidian?
I would say governance and access.
Great. And Karthik?
I'll go with sustainability. Anything that we do, we would want to really sustain this rather than just too many ups and lows in the virtual care space. So I think whatever we do, we got to be make this sustainable.
Perfect. I think amazing. Very nicely put by all of you. I think truly, to me, it's not that complicated. We are already doing virtual care one way or the other. A mom is telling her son to take acetaminophen for a fever on the phone. You're telling your parents to check their sugar. We are getting calls from patients asking for, hey, what do I do next on the telephone? All that is virtual care. Now, our concept of virtual care really needs to become, I think, mainstreamed, where virtual care becomes part of the ecosystem of care. In fact, it will save time, it will save cost. And as we know, the world population is increasing. The number of people who have access to health itself is not that many. And correct me if I'm wrong, colleagues from the WHO, I understand there's only 4 billion people who actually have any form of decent healthcare. There's about another 4 billion who have very limited access to care. Would that be accurate? And would you think virtual care would be a way to kind of solve that problem?
Well, I mean, you're putting us on the spot. I mean, we have the UHC access indicators, and then those indicators are about the essential levels of care and sort of, I mean, the basics that should be done, and it shows the gaps. The challenge is that virtual care on its own is part of the solution, but it does not necessarily address the needs of the people most in need, unless we do a sort of proper processes. So by that I say, I mean, when there is new innovation in healthcare services, obviously the people who are better informed, have better access, are the first to get those benefits. So to make sure that it actually covers the gap, we need the structures that address this issue. Yes, it is a major part of the solution, but we all need to keep that under our sort of radar, to be focused on it and make that the objective to use it for that purpose.
Excellently said. Thank you, Dr. Rush. That's perfectly said.
Hi, if you're well, Dr.
Yeah, go
Sai.
ahead.
Just
Yes,
to
please.
mention another forum, since Hajj season have started and millions of pilgrims are coming, part of the PPP public-private partnership, we have leveraged virtual care in ambulances and also tele-ICU, teleradiology. So mass gathering and virtual care, we can see tremendous value. Just wanted to mention that.
Perfect. I think that makes a lot of sense. Ilona, I know we have only a couple more minutes left. Are there any questions that the audience would like to ask? I know we have a fair number of people still logged on, which is a good sign always.
It is, absolutely. No more questions coming, but there was a good comment about the one-word summary, which is affordable. And I'd just like to mention again the next conversation on virtual care, which will be all about financing. And I'll put the details and the date in the chat. So if anyone wants to attend that, they will be welcome. I can see Arash has raised his hand, but I'd also like to just share
I wanted to acknowledge that, so wrongly raised the hand, so that's absolutely
Thank you. One of the final questions, can any of the esteemed panel members throw some light on how their current virtual care efforts are gearing up for the future, especially the needs of Gen Z and Gen Alpha, as cultural barriers will be their least concern? So that's a very big topic to finish on, but something perhaps about intergenerational changes to finish there.
Jump in actually on that one, in the sense that, I believe it's one of the few webinars where the AI word did not come up till the last minute. So I think AI does play a role as a co-pilot, as a colleague of your healthcare journey, both for the patient as well as the provider. AI is an assistant, and then it is only going to augment care. And from that standpoint, I believe if Gen Z is finding it probably easier to use technology, but I think AI is making technology easy for everybody. And anybody is able to now do a voice chat and ask questions. So I don't think the tech is going to be a barrier anymore. I think it's very important that the cultural barrier will also disappear if the colleague is actually virtual and it's going to meet all the cultural requirements that somebody needs. I do want to go back to what Dr. Rashedian did mention, though. Virtual care is of no use if you don't have the basics. And I think from that standpoint, it's very important we go back to remembering that 800,000 people still die from mosquitoes. There are still challenges where we need to take care of, which we can do as a group together. But I believe virtual care remains a catalyst to initiate that change. Organizations like the IHF, as well as enhanced members like yourselves who are actually taking the time to attend a webinar like this, are the solution. Ultimately, the people are the solution, is what I feel. And I really want to thank Ilona for bringing this together. And I think this has been a wonderful conversation. Thank Dr. Al-Hamali from Saudi Arabia, Dr. Huma from Aga Khan, Dr. Patel, as well as Arash and Karthik for joining in. And really appreciate my own organization for having the vision to indulge in pushing champions like me into the area that I think is going to transform care. So we're good for today, and appreciate all of you taking the time, and have a wonderful rest of the day.